There are two fundamental pieces of information that can be gathered from next-generation testing: the mutations that led to carcinogenesis and tumor mutational burden. Starting with mutational testing, next-generation sequencing with advanced bioinformatics is challenging a la carte testing in the testing market. The advantages of a la carte testing are that it's cheaper, that it's quicker, and that you only get information you know you're going to use. You don't get a big confusing report that you have to figure out. In my opinion, every non-squamous patient should, however, be tested for next-generation sequencing. I'm sold on its benefits in the question of specific mutations for two specific reasons. Number one, for the classical mutations that we know we can action with an FDA-approved drug, it's actually more sensitive. So in my consultative practice, I have had now at least a half a dozen patients who had negative biomarker testing with a la carte testing for EGFR or EML4-ALK, where I've done next-generation sequencing mostly looking for other mutations that weren't tested and in fact had found EGFR or ALK, and in every case the patient has benefited from drug. And there's a published literature backing up that experience. So reason number one to consider it is the greater sensitivity. Reason number two is the greater breadth of testing. In the current era, we are slowly decreasing the size of the pie that is represented by unknown and unactionable. We have new mutations coming on nearly a monthly basis, and they're becoming actionable. If you look at a theme, most of these trials are really, really positive. The newest kid on the block is probably RET, where just a month or so ago at ASCO, we saw some very positive RET data. And so in that environment, where you have greater sensitivity for the FDA-approved targets, where you have off-label targets that you might consider with data behind them, where you have clinical trials of great promise, I think the greater sensitivity and greater breadth of next generation have sold me, at least, in my practice. The other piece of data that you get from next-generation sequencing that you will not get from a la carte testing is tumor mutational burden. Now, this is a much more controversial biomarker. In my opinion, we have multiple data sets now showing TMB to be a useful biomarker for immunotherapy, but what's less clear than whether it has predictive value is how to integrate it into clinical practice. For the context of this question, I would just say that it's useful if you're considering using it, and if you're not ready to use it, then it's of lesser utility. Repeat biopsy with repeat molecular characterization at progression is appropriate only if you can action those results in some way to help the patients. An example of applicability is if you have a patient on a first generation or second generation EGFR inhibitor who progresses. In that case, knowledge of their T790M status empowers you to know whether they should get osimertinib, chemotherapy, or something else. Similarly, if you find one of the rare molecular changes or small cell transformation, it tells you exactly what to do. In the case of the patient on a third-gen inhibitor to start, I think it's a little more questionable how you can use those results. I do reprofile at the time of progression. I consider switching back to gefitinib or erlotinib. I consider clinical trials based upon it. In the case of ALK, I think as we get newer generation drugs coming down the pike with slightly different profiles of which resistance changes they take out, there's a case for repeat biopsy. But if you look at a world where most EGFR patients are starting on osimertinib and most ALK patients are starting on alectinib, I think in a community practice, I don't find it absolutely mandatory to rebiopsy at the time of progression. In my practice, where we have a lot of trials available, I am considering that.